right, thank you very much. On behalf of Gilead Sciences, I'm going to review our pipeline with a focus on treatment and prevention. My disclosures. So I think it's relevant to start with this summary and a reminder of where we are in HIV medicine. These are three of the major international guidelines and regimens that are recommended, are for the most part based on a high barrier integrase inhibitor, although doravirine is mentioned in the European guidelines, and one or two nucleosides. Now, with these regimens, we do a lot of great things. Treatment is prevention. People can live a normal, healthy life. And so we're doing a lot of good with this. So it is a challenge in terms of pipeline to try to do much better than this. So what is it that we've looked at to see how we can make things even better than where we are? Suffice it to say that one of the things that we heard from this morning, for those of you here, was a focus on Hep B co-infection for the roughly 10% who also HIV and Hep B co-infection. The tenafavirs are part of regimens. So I think one thing that I would say about our pipeline is that it's building on these current regimens, not replacing them. And for the most part, our pipeline is based on a molecule called lenacapavir that I'm sure those of you who do HIV are very familiar with. It's a remarkable molecule. It inhibits the capsid. And it has a very flexible PK. As you'll see, it can be dosed anything from orally once a day to parenterally every 6 or potentially even longer in terms of months. And it's a very potent molecule, so it has a really flexible small amount of drug that's needed to create what we'll see in terms of the data. And we're studying it both for treatment as a combination, of course, and prevention. For those of you here yesterday, you saw the results of one of the first studies of lenacapavir in the Capella trial. These are patients who are highly treatment experienced, who had multiple resistance mutations to multiple drugs. We all know in our field the importance of a new drug in a new class. So it was building on lenacapavir and whatever the optimized background regimen a clinician could create. And as you can see, if you just take a look at the missing equals excluded, about 85% of people reestablish virologic control with lenacapavir and whatever the clinician felt was the best regimen to combine with it. And there are several other details on here, including a CD4 reconstitution. We got people out of the danger zone from less than 50 and got them above that. And that we saw, for the most part, stability. I think one of the interesting things in terms of those of us who are clinicians is that the nodules became less severe over time. So even for those 25% who had some degree of a nodule, over time there seems to be a tachyphylaxis or a tolerance to the drug over time. So where else do we go? One approach has been the combination of bictegravir and lenacapavir taken orally. This is an approach that we're taking because we all know from our experience the idea of patients who are on very complex regimens. And I'll show you what I mean by that on the next slide. But we took people who were virologically suppressed on a complex regimen who had no prior use of lenacapavir and no resistance to bictegravir, and importantly, no history of chronic HBV infection. And you can see the rest of the details here. And this was a dose-finding trial of lenacapavir, either 25 milligrams a day or 50 milligrams a day with BIC75, which is the standard dose of bictegravir when used outside of the BF-TAF combination. And compared to a stable baseline regimen, as I'll show you, a complex regimen, based on this trial, the 50 milligrams was preferred, and so that's what's moving forward. Here are the data in terms of the patients who participated, and I'll look at that table on the right. You can see at the top in the table, these are patients who've had HIV treatment for about 30 years. So from those bad old days of indinavir and sequinavir and so on and so on and so on. So what are the regimens that people are on? And it's usually, for the most part, a high barrier integrase and high barrier protease inhibitor. And then whatever else the clinician felt was needed. Nucleosides, non-nucleoside, attachment inhibitors, whatever the clinician felt the patient could take that was necessary to reestablish virologic suppression. So these patients had a viral load less than 50 on these complex regimens, and you can imagine that replacing all of this with a single tablet of bictegravir and lenacapavir would be welcomed by the patient. So that's what we did. We were able to replace all of those antivirals with lenacapavir, and maintained bictegravir in these patients, given that they had no bictegravir resistance. Those patients on a complex regimen did well. These are patients who are good at taking all these tablets, but welcome the idea of replacing all this with a single tablet. And as you can see, we maintain suppression in essentially all of them. This is the week 48 data. For those of you who like to take a look at footnotes, you'll see that we had a few people who were above 50 copies at week 48, but for the most part, at their next visit, they resuppress to less than 50 at their next visit. So essentially all maintaining suppression over time. In terms of the dose finding, you can see on the right side in the table, there's no evidence of more adverse events at the higher exposure. And since the higher exposure was associated with more of a cushion in case of missed doses, we went with the 50 milligrams. Now, there's a long history in our field of people taking once daily regimens and taking them less than once daily. There's a long history of suboptimal adherence in our field. It has been a fascinating topic for many years. So much so that some studies have been done of actually exploring this in randomized trials. And probably the most extreme of which was presented at the Retrovirus conference just a few months ago, based on a study done here in Barcelona. This is BF-TAF in a small pilot study of about 10 people per arm, taken once a day, or instead 3 days a week, 2 days a week. So 3 days a week is Monday, Wednesday, Friday. 2 days a week was Tuesday, Friday, or 1 day a week, to see how forgiving this regimen was in people who missed doses. What would happen in people who missed this much? Interest in all of this prompted by clinicians who talk to patients who say, yes, I don't feel like taking your pill every day, so I take it less often. So on the left is evidence that people did follow the prescription. The bictegravir exposures were quite low. And what they saw is on the right side, if we just take a look at the viremia, in people who were on the once a day, there was no viremia as expected. With 3 days a week, there was 1 out of the 10. Twice a week, there was none, although I think it's fair to say that's just the power, since with once a week, there were 2 people. So suffice it to say, their daily exposure is necessary. In the absence of daily exposure, there's a chance for viremia. And all of us know that resistance to antivirals happens when there is viremia in the presence of an inadequate amount of drug to suppress the virus. They did not observe any treatment-emergent resistance on any of the arms, so I would say that's good luck and lucky. But certainly, if there's interest in once-weekly dosing, instead of stretching antivirals that are designed for once-daily dosing, here's where we're going in the pipeline. We are partnering with Merck, so we have, of course, lenacapavir, which can also be dosed once weekly at a dose of 300 milligrams, partnering with Merck in terms of islatravir, which can be dosed at 2 milligrams, taken once weekly, and a randomized study versus daily BF-TAF. And you can see the results here. Essentially, all patients are virologically suppressed. There was no evidence of viremia in either of the 2 arms. And as you can see at the yellow box on the right, adherence was excellent. Essentially, all patients took their assigned dose. It's been interesting to travel the world and speak to people about this, since there's a lot of controversy around a once-weekly regimen. Some clinicians love it. I don't want to take a pill a day, and a pill a week sounds great to me. And other clinicians say there's nothing that's once a week. So how do I teach somebody how to do this? And so what is once a week? I mean, some people go to shul once a week, but not too many. And some people have a Sunday roast in London. That was their popular thing. So there are things in life that might be once a week. But again, for this to be an interesting regimen, that will be one of the conversations of a clinician is what else do you do that might be once a week that can take advantage of the properties of this regimen? Now, in terms of the safety, there's been a history of islatravir at higher exposures of lymphopenia. As you can see at the right, no change in CD4 count, no difference between the CD4 between the arms, and no evidence of lymphopenia. The regimen was well tolerated. There was 1 person with dry mouth, 1 with nausea. Other than that, a well-tolerated regimen. One thing that our field has talked about for quite some number of years is changes in weight. Do antivirals cause weight gain? I'm proud to say that approximately a year ago, the three of us on the panel, Jean and Raphael and myself, are co-authors on a summary publication in CID last April that summarized what we have learned, what we think we have learned about weight change and antivirals. Suffice it to say, I think what the article shares is the data in support that really no antivirals contribute to weight gain. People are gaining weight on antivirals, but certainly there's no evidence that antivirals necessarily cause that weight gain. And as you can see here, we saw no increase in weight in the two study arms. So where we're going are larger randomized phase 3 trials. We call this the Island Project, since it's islatravir and len, and I thought that was pretty clever. The Island Project is one way to remember this. Now, this study is islatravir len once a week with a BF-TAF placebo versus BF-TAF daily. Since this is placebo-controlled, this doesn't take advantage of once weekly dosing to see how people experience it, but this is a standard double-blind comparison of BF-TAF versus islatravir len in a double-blind trial with data through 96 weeks. And this study is ongoing. But we do have a companion study, and this is comparing islatravir lenacapavir once weekly to a standard of care regimen. The standard of care regimen is essentially any guidelines recommended regimen, integrase, non-nucleoside protease-based, any of them, plus the nucleosides, and comparing it to once weekly islatravir len open label. So people get either a once weekly tablet or their standard of care regimen. And we will see what happens with this approach, including patient-reported outcomes to see, do people like this more? Is this more convenient? Is this more liberating? Is this less tablets and less to think about? We will learn from this trial from a large number of patients, what is this like? Then, in terms of once weekly, there is obviously interest in integrase inhibitors. So we've been working on an integrase inhibitor that also has the potential for once weekly dosing. It's called 1720. This is the dose finding trial that found that at the higher doses, it had about a 2.5 log drop. And so we're going with one of the doses that's on here. It also had to have a high genetic barrier to the prevention of resistance. And so this is a standard fold change versus the various mutants. And you could see, of course, elvitegravir, raltegravir give up with one mutation. And you could see BIC, it took 3 mutations and a specific 3 in order to lose bictegravir activity. And 1720 has a similar high genetic barrier profile. And then finally, we're planning 2 phase 2 studies comparing 1720. 4182 is a prodrug of lenacapavir that allows it to be dosed once weekly in a smaller tablet formulation, comparing it to BF-TAF, either as a switch or even in those who are treatment naive. And then finally, we're looking at lenacapavir subcutaneous every 6 months or every 26 weeks. Along with 2 broadly neutralizing antibodies. It's difficult to find other antivirals that have a Q26-week half-life. But bNAbs can, and so we've identified 2 that appear to be very active. Patients are screened so that these bNAbs are active for them. And they were getting a dose of lenacapavir subcutaneous. It's 2 subcutaneous injections, and then an infusion of tab and zab, tirupavimab, zinlervimab. Takes about 20 minutes for each infusion. And this is the result of a phase 2 study at week 26. As you can see, essentially all patients were virologically suppressed on their standard background regimen or on after this first dose of len with tab and zab. As you can see, there's 1 participant who is viremic, and we're trying better to understand what happened there. But in essence, of course, we are learning from this what to do in order to minimize the risk of rebound and viremia. That's what these phase 2 trials are for, is to teach us new data. We can say it was, however, not evidence. There's no evidence of anti-drug antibody as the relevant factor here. And then finally, prevention. Lenacapavir, of course, having a very exciting summer of sharing the data on prevention. This is our purpose tree. Hopefully you're all aware of the purpose 1 data. That was adolescent girls and young women in Uganda, South Africa. Purpose 2 is a much more diverse trial of people in many countries around the world and gender diverse populations. Purpose 3 is in the U.S. of cisgender women. Purpose 4 is in the U.S. of people who inject drugs as their exposure for HIV, since we have animal data that lenacapavir can be preventive both from rectal exposure, vaginal exposure, and parental exposure. And so we are working on understanding the role of lenacapavir as prevention. Since this pandemic is only growing year on year, how do we get control of it? Treatment is prevention, and despite where we are with treatment, there are more cases of HIV per year. So oral prevention works, and some people are good pill takers and some are not, so thus these studies. The Purpose 1 study was shared this summer at the Munich conference. The background incidence based on a recency assay is around 2.5% of new infections, and on lenacapavir, there were no HIV transmissions. On FTAF and FTDF, there were some, and as you can see, minimally different from the background incidence, which we believe is simply based on just a lack of pill adherence in this population. Whereas LEN, there's no adherence. People came in, and about 95% got their subcutaneous injections and did quite well with virologic prevention in essentially all of them. In Purpose 2 was much the same. There were 2 transmissions out of the roughly 2,000 person years, so doing quite well in terms of preventing cases of HIV. And then finally, since every 6 months is fascinating, the formulation chemists decided to stretch it even further. Very interesting study when it was presented at CROI. This is now looking at once yearly lenacapavir. The gray line is the standard exposure with lenacapavir every 6 months. And this is the formulation with lenacapavir once yearly. And as you can see, at the Cmin at week 52, we are still above what's needed based on Purpose 1 and 2. That would be preventive with a once yearly injection. This happens to be 2 intramuscular injections. Formulation, we're working on the amount of drug that's needed, the amount of dosing. And as you can see at the right, also working on safety, since it was identified that simply pre-treating the injection site with ice prevents the initial pain that happens with the injection. Again, and that's just pain in the first 2 days with ice. Again, this is once yearly, and after that, the person is pain-free and has the benefit of a protective antiviral. So in sum, we believe lenacapavir builds on where we are now for people with HIV and people without HIV, and is the focus of this pipeline. Lenacapavir was first identified as a molecule to be developed when a triplet was the most popular regimen, perhaps globally, in 2006 in the US, announced as the advanced accomplishment of our era. And some very smart people at Gilead said, I think we have an idea of where we can go from here. So as I've shared with you, we have the oral once daily BIC-LEN being explored for people on complex regimens who like the idea of a pill a day. A lot of people find that comforting. Every day I take this to protect myself from HIV. I take my statin, I take my antihypertensives, and I have my HIV tablet right here. We are exploring the once weekly, as I've shared, the twice yearly treatment approach, and perhaps even longer than that with prevention data, with our Q6 month data that's being evaluated by what's left of the US FDA. There are a few people left in the office that are evaluating antivirals that hopefully will announce their decision in the month of June to share whether this is an approvable drug. We certainly hope so, with the idea that we might have even longer dosing intervals in the future. So with that, let me thank you for your kind attention.